So just to elaborate on what John just said is, so one of the biggest reasons why, if you ever wonder why the meeting is actually here, and I remember this from 18 years ago, and I remember him saying exactly this, it was to bring industry and doctors together. And that's one of the biggest reasons, and he used to say that all the time. And John knows that, and some of the other people that have been here a long time know that. And so take that time, look at new technologies. You're a spine surgeon. Some of you guys are obviously just in practice, or you're fellows right now. Take that time and really go walk around that room, look at new technologies, look at something that you could be interested in. I mean, I heard a talk 2 years ago from Fessler, and then I ended up incorporating that into my practice today, and we'll talk about that some. But just so you guys understand, it's extremely important from a vendor standpoint that you go over there and you take that time, especially obviously early in your practice. So that's obviously something that I'm learning now. So to go into that with new technology, first we're going to start with basically it's expandable technology, and obviously it's everybody's really seen this this slide here. Personally, I'm going to talk about things that I do and things that I incorporated into my practice as of recently to in the past. Obviously, the things that I do are O-lift, I do X-lift and laterals, and then T-lifts. Personally, I don't use very much expandable from an A-lift. I haven't done that. I haven't seen much from a utility standpoint personally, but I could see some benefits with it. So obviously, what are some of the big benefits with expandable technology? I think the biggest one to me would be, especially from a lateral standpoint, it's such a larger graft and obviously much less chance of subsidence. I think you can increase the segmental lordosis and decrease risk of your neural injury, especially with these grafts that are obviously going in much, much smaller. And we're seeing this more and more where these grafts are becoming smaller, but their footprints are obviously incomparable to, some of them are even comparable to A-lifts. So when you talk about expansion with these types of grafts, you have vertical expansion. Here's one, ProLift, obviously not very large footprint, really a preset lordosis. You're going to have some indirect decompression, obviously, because you're increasing the intradiscal height. But I think to me it was harder to get good correction from a lordotic standpoint with these types of grafts personally. Here's another one here. Then you saw grafts like this. This was the lattice from Globus. I think NuVasive have one called the MLX, or Globus technically now. These grafts are good from a standpoint, obviously, with the footprint, and you can deliver a significant amount of bone graft in the center, obviously to promote fusion. I think the footprint is the biggest part to me, because obviously the subsidence rate, right? We end up with these smaller grafts like the ones you see above, where they're placed, and they end up subsiding through the end plate if the patient is osteoporotic. And I think what we're starting to see now is grafts out like this. Personally, I have not had experience with this graft. I do like that it obviously ends up it goes in almost the size of any of those other T-lifts, but then it's obviously expanding where you're gaining lordosis, and you're also gaining, it's basically horizontal and vertical expansion, which I think is kind of where you're seeing more and more grafts coming out like that nowadays. How they're going to do in the long run, that's obviously only time will tell. So with approaches, as mentioned, you have A-lift, which the Globus Magnify. I think I would say probably the biggest benefit for me personally, thinking about this, and I haven't used it, would be obviously less passes with a sizer, less passes with an implant. Obviously just placing the implant and then expanding up, obviously, to try to gain the lordosis that you want. But I feel like you can gain enough. Personally, I feel like when you cut the ALL, you're able to do that with a static graft just as successful personally. Things I've adopted recently would be the PTP procedure, or ATEC. So I started using their expandable, which is Calibrate, and I've used Lifespine's expandable from a lateral position. Both of them go from about 5 to 15 or 20 degrees in lordosis. They do have a big, large bone window that you're able to end up placing bone graft before you place it, and then you can backfill that area as well. And this was a case I had done the other day. And you can see they have good fixation points onto the vertebral bodies. I think this is really important, especially if you're somebody that's doing anterior column releases, or if you're somebody that's maybe a big PSO guy. But I think you can get your lordosis here instead of doing obviously a much more morbid procedure like a PSO, or even it may prevent you even just doing even a posterior column osteotomy. The one at the bottom is that one's ATEC, and the top basically is very similar device, 2 fixation points. Obviously, if you're doing an anterior column release, it'll prevent you obviously from kicking out anteriorly. I think we had a talk a few years ago about a disaster case like that where they tore the ALL and ended up kicking out anteriorly. This is that's actually that case. This was mine. I didn't end up expanding it as much as I wanted, but I was a little nervous because you had a really calcified aorta. I didn't want to really stretch that and give him a dissection. This is just another image. This was the life spine. Yes, I did it. And personally, I don't do just standalone. I back them up all the time. So this image, you're kind of wondering, I get it. The distal end of the construct absolutely looks horrible. So to elaborate on this, I don't have an exposure surgeon. And this kind of lead me into the next graft that I use personally. So this was a case that I wanted a stage procedure. I was going to do a multi-level lateral. I can't remember there was something going on, and I couldn't get 4 or 5. So I ended up doing obviously posteriorly and doing T-lifts at the bottom. I absolutely hated that construct, and I had a bunch of them because I lost my ALIF exposure guy. So I was like, I got to figure out a different way to do this. I got to figure out to have something at the bottom of the construct that's much more stable. You know, it just looked really funny having 3 levels of laterals and then this little dinky T-lift at the bottom. You know, and obviously that's your highest rate of pseudoarthrosis. It's going to be at the bottom. So that's when I started exploring other options and actually heard the talk. So the 2 grafts that I've personally used from an expandable standpoint are the Medtronic Catalyft and PL, and then this, which is the Luna. Some people have used it, some people haven't. I have gone through ups and downs with Luna. My nurse practitioner can highly tell you that. Personally, I've worked through them, but what I love about Luna, it comes in at 7 or 8 millimeters, very small, can expand. I think the highest, I believe is 14, but it provides that footprint that I was looking for at the distal end of my constructs. And it provided an area that you can, significant amount of bone graft in the center of the graft, as you can see. So this was something that, and I think it was Fessler that did a talk a few years back, but there's definitely some nuances with it. This is just showing how it actually expands up. There's a bone delivery device at the end I'll show you here. This is just an image of the previous T-lift. So how Luna humbled me a lot of times. Everybody in this room is going to say they do the most perfect discectomy. There's not one surgeon in here that's humble enough that says they suck at it. So I felt like I did enough discectomy all the time. Well, with Luna comes in and does a big swoop where it'll hit that contralateral, basically disc material. And what was happening was I was placing it and I was having a hard time and it was pushing me back. And I would go back in there, and what's nice is with that orbit, with the rotating shaver, I would come in straight, rotate that shaver, and what I started to do is shoot it way over to that contralateral corner and really, but it'll add another 3 to 5 minutes of discectomy on your case, promise, for every level. Because it shouldn't be so difficult when it expands, when the Luna comes out and expands. And that was something that I had to learn and kind of work through. But once I kind of figured that out, what's nice is that you have the rotating shavers, a disc prep, they go from 7, 9, 11 millimeters, and then you have the decortication instruments that rotate as well. I would like them to be a little bit more robust, but overall I've been pretty happy with them. I would like them to make them a touch longer too, to be able to sweep that end plate. But this is some technology that I think is extremely beneficial. I think can be incorporated one way or the other, whether it's into lateral procedures of doing discectomy and that, just being able to pass obviously less instruments back into the disc spaces over and over and over again. And I think that's definitely something to be utilized. And if you haven't tried it, you definitely should look at it. This is the part there. You can see basically there's a device that goes on the back of the Luna, and you're able to end up delivering the bone graft. And I like that because it keeps it obviously in the center and provides enough bone graft obviously for fusion. But you can see obviously the size of the implant itself is much more robust than some of the other smaller expandables that are out there. If you look closely in the center of that screen, obviously there's a lot of stuff, so I'm distracting off the module heads, but what you can see is that nitinol wire actually going around on that Luna. So and you'll see one of my cases where I just couldn't get the thing to turn all the way around. But you can see basically the inserter, and then you can see that nitinol wire making that turn all the way around. That's basically telling you, now you can expand that graft and be pretty successful with it. Also, I know that some people are like, how the hell do you remove the thing? It was actually I've removed it before. It's actually pretty simple. They have a pretty good step process for that. So if you're kind of wondering how you would get that out after it's expanded, it's not that bad. This is just a few images of the cases. Obviously, you can see all the way up anteriorly. I try to keep it resting up against the ALL. But you can see both of those grafts they're a little offset, but you can see kind of that nitinol wire all the way around, which basically tells you that what you'll see on the other one, you can see that top image. So this is a lady that I had done a PL40 graft in the middle, and then she got adjacent level above and below. The bottom one, and you can see that image, that graft ended up coming all the way around. I was having I spent a lot of time, and for whatever reason, the top graft wouldn't make that full turn. So it ends up staying somewhat open, still able to pack a significant amount of bone graft in there. I just felt at that time it was time to move on from the procedure, and just ended up putting a lot of bone graft around that. But obviously you wanted to make that full turn. I just wanted y'all to see what'll happen, because if you end up pushing it in, it'll end up basically staying kind of open for you. Just a pre and post-op, just grade 1 spondy. Nice reduction there. So looking at the research, look at a few talks here. So this one this was comparative effectiveness of a laterally placed expandable versus static. It had a significant lower subsidence rate, greater segmental lordosis, better VAS and ODI. Just to run through these quickly. And then Luna, this was actually a Luna study which showed a 93% fusion rate at 1 year. Disc height went from 8 to 13 and 6 to 9 posterior height. Another one that was a Luna study. This had 98% fusion rate. Again, my biggest thing, 1 case of subsidence, 1 case of migration. So that is my biggest thing, especially at the distal end of the construct. I'm at a hospital. I'm not in private practice, so I have to be careful of obviously what instrumentation I use, because we're under certain contracts. So they allowed me to use this obviously because it's at the distal end, and I needed something better than obviously what was out there. This was just a meta-analysis. Really no change in obviously ODI versus when you're talking about versus static cages, but again, increase in segmental lordosis, increase in anterior disc height. Another very similar to support it, lower subsidence rate, operative time. And I think the operative time comes obviously because we're not having to end up multiple trials. Personally, I don't really place as many trials now that obviously I've converted basically all expandable grafts. I thought was interesting. When compared to an A-lift, the deployable expandable T-lift cage demonstrates biomechanical equivalence in regards to segmental stability in the coronal, sagittal, and axial plane. So that's obviously very nice, especially if you're not an A-lift person or you don't have an exposure surgeon. This gives you an option at the distal end, obviously, to provide that stability, and you're obviously not going down the route of, having a chance of a vascular injury and so on. And then this was actually one, and he must have left on me, but it's the first time a Weinstein and a Castellvi have ever agreed on something in history. But he actually just published this, and I know this wasn't with Luna or an expandable that I used, but overall improvement in VAS and ODI, and improvement in segmental and lumbar lordosis with the expandable graft that he was using. So in conclusion, again, I haven't used the graft on the other side. I've used the Luna. But I think you're starting to see more and more of these grafts out there. I think you're starting to see much better increase in the lordotic side of it, and increase in the footprint. And I think all of this really need to, if you're a big T-lift person, really need to start looking at those things and try to obviously get a bigger graft in there if you can. Thank you.